Hello and welcome to the World Extreme Medicine Podcast. I'm your host, Stephen Wood, and I'm an EM and critical care nurse practitioner and medic with over 3 decades of EMS experience here in the Metro Boston area. I'm joined today by Dr. Sush Prusty. Dr. Prusty is an emergency medicine doc and pilot and a FAA Flight instructor. He has over 10 years of service in the U.S. Army as a flight surgeon. He is the mastermind behind My Heart MD and has a special interest in EKGs. And today we're going to talk about EKG findings and arrhythmias in hypothermia. And Dr. Prusty, I understand we're going to start off with a case. So why don't you go ahead and lead off with that, and then we'll chat about the case and some questions as they arise.
All right. Well, Stephen, thank you so much for having me on. It's my pleasure to be here with you, and hopefully this will be a educational discussion. Now, let's start off with a case, and this is something that we see all the time, and I'm sure you do too. This was an 18-year-old obese male, a diabetic obese male from one of our local universities who came in by paramedics after being found in a snowbank. And unknown downtime, he appeared intoxicated. There was some alcoholic beverage, empty cans and things like that around him. And on their evaluation, he was, minimally responsive, but not really that much to both verbal and tactile stimuli. How does that sound to you? Something you've seen before a little bit?
Oh, yeah. This is, it's something I think we see here in the Northeast. And I know, many of our listeners who come from colder regions, both here in the United States and abroad, found in a snowbank is a fairly common complaint, I'm sure.
It's classic, right? It's found in a snowbank. Well, that's right. And paramedics got vital signs as follows. His blood pressure was 90 systolic over 60. He was bradycardic down to about 45 beats per minute. And his tip-bag temperature was 82 Fahrenheit. It's 27.8 degrees Celsius for our listeners outside of the U.S., right? And his fingerstick blood sugar at the time was 420. So, common presentation, common mechanism, but a complex case all at once. He was actually brought in by paramedics and en route to the hospital in the ambulance. He became less responsive and somewhat more bradycardic, with his heart rate dropping down to less than 30 or so. And so that's what we have. We have an obese young male who came in, and prior to coming into the hospital, he actually lost his pulses and was completely unconscious. And this happened actually just as he was entering. So appropriately, they started CPR immediately, and they pulled into our trauma bay with CPR in progress and handed him over to us. In the ER, at once it was realized that this was in fact going to be a difficult airway. No question about it. He was obese. His mom potty was somewhere between 4 and 5. CPR was continued, and he was intubated immediately. And pacing was attempted, actually. Pacing, we'll talk about that a little bit, but pacing was attempted. He got a little bit of atropine, trying to get his heart rate up. Nothing really helped. And so CPR was continued for the entire time that he was warmed. It was quickly recognized rectally that he was extremely hypothermic, as the paramedics had already established. And so he underwent both passive but active warming. And it was a prolonged case, all hands on deck, everybody involved, young patient, don't forget, I go back to that all the time. And eventually he had ROSC, return of spontaneous circulation. All right, so that's the case.
It's a great case. It's a great case with a lot of interesting pieces to what we want to talk about today. And I want to dive into, some of the cardiac issues that arise with hypothermia. But let's first, many of our listeners are involved in austere medicine and in expedition medicine, are familiar, but some are not, or come from tropical regions where this is not a common presentation. So let's first talk about hypothermia. how do we define hypothermia? I know there are a couple of different classification systems, but how do we define hypothermia, and what kind of tools did you use to kind of determine that this patient had, was suffering from hypothermia?
Yeah, I think it's most, I think generally recognized that a temperature of less than 95 degrees Fahrenheit or 35 degrees Celsius is pretty much what we call hypothermia. It is also important that you obtain the temperature in a reliable way, like rectal temperature, which we did, and not just assume that a tympanic temperature or forehead scan is going to be good enough to determine this diagnosis of hypothermia. It's also important, given our audience tonight, it's important to recognize that, who's at risk, right? The extremes of age, people at risk. So we're talking about infants, younger people, but older people also. Older people also at risk. And it's interesting that 50% of all hypothermic cases are over the age of 65, right? That's an important thing to, I think, realize. And so it's extremes of age, number one, but also in regards to this discussion, it's also extremes of temperature and environmental conditions, right? That's the important thing also. So if you look at causes, certainly there's accidental causes, patients like this case, as the guy was found in a snowbank, he had no idea why really, right? But he came in, there are metabolic causes, there are infectious causes of hypothermia, and drugs and alcohol are important to understand and recognize as an important cause, because in the United States, it is the most common. All right, it's the most common cause of hypothermia around here, at least.
No, it's great. So I assume that you guys were able to get a temperature rectally. But what's important to kind of note from that is that your standard thermometers are generally not going to be able to measure extremes of hypothermia. And so it's important to have a rectal thermometer that's specifically a hypothermia thermometer. A lot of emergency departments will have specific kits for that. Other method, and one caveat to that is it's important that really cold stool can actually interfere with those measurements. Other ways to measure temperature include esophageal, which you mentioned, and also urinary catheter. You can also measure temperature through a central line, although you're not going to have a central line that quickly in this kind of patient. So that's a great way. That's important to know, that you need to identify temperature using modalities that are probably less familiar to providers. And second, if outside of being able to measure a temperature, there's also the Swiss method, which uses symptoms. This patient would have obviously been classified as pretty severe hypothermia. So you guys were able to recognize it quickly. Certainly, it probably helped that he was found in the snow. But we know that you can also, become hypothermic in other environments, even in a residence if it's cold enough. And so you've got to think about those clues. So let's then talk about, we've recognized he's hypothermic, and we know, he's severely hypothermic based on his presentation. But what are some of the clinical stages of hypothermia that you think about as a clinician when you have these patients coming in?
Yeah, I think as you have seen, I'm sure these patients, they come in with different presentations, and so we tend to divide them up into sort of mild, moderate, and severe hypothermia for a variety of reasons. And just for definition purposes, mild hypothermia is typically between 90 to 95. Again, for our listeners outside the U.S., that's 32.2 degrees Celsius to 35 degrees Celsius, right? And the reason why that's important is because this is the stage in which shivering actually occurs. And shivering is a tremendously effective way for the body to self-regulate and bring that temperature back to normal. And as long as the patient is shivering, that's a good sign, right? We're going to keep letting that patient shiver and doing their part in thermoregulating, thermogenesis. All that stuff is important to help him come back to, or her come back to that normal level. There's also in this stage some level of confusion, and we see that pretty commonly. The next sort of phase or stage, clinical stage, would be moderate hypothermia, and typically this is between 86 to 90 degrees Fahrenheit, which is about 30 to 32.2 degrees Celsius. And in this stage, you tend to see some sort of bradycardia, slowing of systems. Importantly, in this stage, shivering stops, right? Shivering stops. There's obviously more confusion, more changes within the brain. And this is the phase in which we start seeing things like ECG abnormalities. And the most commonly seen one is sinus bradycardia. But we also see something that is always tested on our board exams. We call that Osborne waves. And that's when these findings tend to appear on the electrocardiogram. Now, we'll talk more about that, the Osborne waves and what they mean, and a little bit about that. But the next phase, the next stage is severe hypothermia, where the temperature tends to be below 86 degrees Fahrenheit. And here's where, patients get awfully sick. Severe sinus bradycardia and, all kinds of abnormalities in their rhythm, which can be anything. It could be asystole, PEA, VFib, anything is possible. And the reason for that is that under cold temperatures, the myocardial tissue is very, very irritable. So anything you do can have a detrimental effect on the heart. And we just say things like, don't do CPR. Well, that's silly. You got to do CPR in a patient who's asystolic like this. But you got to take into consideration the potential for causing myocardial irritation, things like that, and worsening outcomes because of the fact that you're actually irritating the myocardium. So those are the things that we tend to see within those three clinical stages, Steve.
Okay. No, those are important kind of things to think about when you're assessing these patients and using that clinical data in conjunction with the history, the exam findings. We all, in pre-hospital medicine, we rely on those things all the time. In emergency medicine, and especially in the ICU, right? We rely on things like imaging and labs for a lot of our diagnoses, and frankly, those are not as useful in this kind of scenario. You're probably going to get a CT of that gentleman's head. You're going to get a chest X-ray, but your clinical presentation and the history is really what was most important and what kind of clued you into what was going on. So let's talk about EKGs. And if I was really sophisticated, I would be leading in here with Crazy Train by Ozzy Osbourne, because I think that's a great kind of, he did not invent the Osborne wave as I thought so many years ago, but he still is one of my favorite performers by far. But let's talk about the EKG, because there are some interesting findings in the EKG. And there's one really kind of, definitive finding, what you kind of led into, which is that Osborne wave or the J wave. And I know it goes by some other names as well, but what are some of the more common EKG findings? And then we can talk a little bit more about the Osborne wave and what its significance is as well.
Sure, terrific. We'll get into that in a second, but just to kind of make a comment on what you had said, these patients come in, and it's super important to make sure they really are hypothermic, and that's why they're behaving the way they are, and not because of something else, right? So a fellow found like this could be trauma, could be head injury, and guess what head injury does? Osborne waves too, right? That's one way they can present. So it is really important that you assess a patient like this kind of globally, and not just say, oh, look, his temperature is low, so it's got to be hypothermia for all his presentation. Can't say that. So this sort of a patient needs a sort of a full trauma workup along with a workup for hypothermia. So I just want to say that, because that's an important thing. We need to prevent ourselves getting anchored onto
Right.
one thing you think might be the case. So going on to Osborne waves, Osborne waves are, the reason why they're so important is because, you know why they are so important? Because they're tested on. Every ER board exam question absolutely, definitively, has it. No matter what you're doing, they have Osborne waves on them, so you got to know about them. That's why they're important, really. But they're very non-specific, and they're absolutely not pathognomonic for hypothermia. And I think you mentioned it, John J. Osborne was, in fact, not the person to first, report it. It was first reported by a guy called in 1938 or something like that, by a fellow by the name of Tomaszewski. And he reported it, but John Osborne is the one who first published it, I believe, in 1952 in a journal, I think the American Journal of Physiology, and I think it was dog studies that he studied, the dogs that he studied, and made a very eloquent observation. And in his, in respect to him, that it was actually called Osborne waves, but they are also called sort of a multitude of things, and they're called Osborne waves, but they're also called things like J waves, which I really think is confusing. I'll tell you why. They're also called late delta waves, and there's something called the Hathawk sign or the Hathawk junction. Multiple names for the same finding. I like to call them hypothermic waves, right? Because that's what it is. That's what defines them. But be careful when you hear these different terms, and especially be careful when you refer to these as J waves. And the reason for that is that J waves can easily be misunderstood as the J point. Two very different things, right? J waves are essentially a depolarization, late depolarization abnormality that you see in patients who are where the heart is very cold. But the J point is something that is a different location, usually after the J wave, and it marks the transition between the QRS complex and the ST segment, right? It's usually right there at that point where we call the J point, and that is how we define ST elevation MI, right? Not the J wave itself. So because of that, I think it's confusing, and we should really get away from these little, these very specific and I don't know, I think misleading names. So they're Osborne waves or hypothermic waves, something simple that makes us understand exactly what this is and not to confuse it with something else like the J point. So it's also important, I think we mentioned this before, that you see this a lot, okay? You see this a lot in patients who have hypothermia, usually below 30 degrees Celsius. However, it is not pathognomonic, right? It is not pathognomonic of hypothermia. As a matter of fact, I'm not even sure how many, but there's a bunch of different causes, and there's I think vasospasm causes it. Certainly, traumatic brain injury will cause these things, these Osborne waves. I think in terms of metabolic abnormalities, calcium hypercalcemia causes it. Sepsis, I believe, can cause it also. Brugada can cause it also. So there's a bunch of things that can present with these little Osborne waves that can be misleading. So the history is really important, and confirmation of a true rectal temperature is really important before you call it what it is, a Osborne wave secondary to hypothermia. So let's just be, I think, just be mindful of that.
Yeah, no, I think that's important. And, we in medicine, well, let's go back to just the naming of the Osborne wave. That is so common in medicine, right? That it's not the person who initially discovered or, discovered the finding. It's often the first to publish. That's a whole other series that we could be talking about. But I think, it is confusing, and we should just be talking about, these waves for what they are, which is hypothermia waves or things of that. I think that's probably a better vernacular for defining that, and knowing that, it's not pathognomonic. It's not only hypothermia that you might see these waves in, but something clearly to think about when you do see an Osborne wave. One of the other things I've learned is that the degree or the height of the Osborne wave can correlate to the degree of hypothermia. Is that something is that a truism, or is this another one of our kind of medical mythologies like vitamin K anaphylaxis and contrast-induced nephropathy? Is that where does this beast lie in mythology, in mythology or reality?
I think it's up there, man. I think it's I've heard that too, and I've seen cases where it's kind of like the hyperkalemia EKG, right?
Right.
The degree of the T wave, peak T wave, does not really correlate that well with the level of the true level of hyperkalemia. So I'd be careful with that one, because I just haven't seen any studies that say, or if there are, I haven't seen it, that there's a correlation between the height or the amplitude of the wave and the degree of hypothermia. So so
it's something to think about, right? Yeah,
right.
It's one of those things that we hear about, and whether or not there's some truth behind it remains unclear for sure. Can we talk about defibrillation and pacing in hypothermia? I actually wrote an article on this in the Journal of Emergency Medical Services. I think it was back in 1996 or 97. I don't even know if it's like in PubMed or even exists anymore. And I'm sure things have changed. All that information was really in animal studies. They're clearly it's not ethical to do a randomized controlled trial of this kind of intervention. But what's your understanding and experience with both pacing in the setting of hypothermia and defibrillation?
Yeah, so I think that the teaching, first of all, was way back when I was in training and all that. It's like nothing works. Like a cold heart, nothing works. So you have to not do anything really, or do minimal things, because you can really like jostle the patient and they go into a malignant rhythm. I think it's swung a little bit into saying that you got to take care of the patient first, right? Understand that a lot of these therapeutic measures, cardiac meds, pressors, atropine, as well as things like electricity, just aren't going to work when we have a severely hypothermic patient. They're just not going to work. So the teaching, I think, that I feel most comfortable with is to, if a patient's in cardiac arrest, you got to do the cardiac arrest protocol. You can't say, well, they're cold, they're not going to do anything, right? That's a chip shot. But then, so what's next? I would say, you got to initiate things like even shocking. It'll probably not work in severe hypothermia, but it's worth a try while you continue to actively and probably invasively need to rewarm these patients to the point where they're out of the severe range of hypothermia, and then they might have an effect. And it's okay to pace a patient, just it's probably not going to work. And if you're having, this patient was paced, they attempted it and it didn't work. And I think one attempt of something like that is reasonable, because you got to do something. But if it doesn't work, I wouldn't keep doing it. I wouldn't shock. I've heard of cases where it was like shock, 15 times and nothing happened. And it was a patient who was actually was hypomagnesemic, like severely. Well, you have to treat the cause, right? Similarly, you have to treat this cause while you're doing things in conjunction. What's your experience with it? I think that people are stuck here, right? We had to do something, right? We had to do something, but you do it, and CPR, effective CPR, might just be all you have, while you're doing a peritoneal lavage. To get that core temperature just up into the moderate range where these effects will be useful. These interventions will be useful. So what has been your experience with this?
I think the same. And I think, one of the pitfalls of ACLS and other, programs of its type is that this kind of resuscitation becomes too protocolized, right? It's I back in the day when it was shock, epinephrine, shock, we used Bertilium in the setting of hypothermia if I'm dating myself there. But,
That's right.
I think, and they reserve, this kind of thinking for PEA. But I think with every cardiac arrest, you really need to kind of think, what's my cause? What are my interventions? What's going to work? What isn't going to work? If I'm doing something and it's not working, what's my next step? And really stepping out of the box in any cardiac arrest situation, thinking about, what's working, what isn't working, what's my underlying cause. I think in the setting of hypothermia, you're not going to continually shock someone. I think you're right. Give it a shot, see what happens. Pacing similarly, but if it's not working, continue rewarming and then try again when you get to a temperature where you might have some success. But just continually stopping to shock the patient, you're causing delays in CPR, and that's really going to put you behind the 8 ball. That in this scenario, rewarming is most important. Get them to a temperature they need to be at, and then maybe retry those interventions. So I think that's, I think what you bring up is great advice. Let's follow the standards. Let's do an intervention, but let's not anchor on it. And if it's not working, move on and think of other things. And sometimes you may need to do just continuous CPR until you get to a point where these interventions have a better chance of being successful. I think similarly with medications, they're not going to work, when someone's too cold. Once they're rewarmed and those enzymes, are functional and those receptors are more functional, then you might want to try those. So on that same topic, you've mentioned, several methods of rewarming. So when we'll leave mild and moderate hypothermia out. That's, kind of been covered in previous podcasts and talks and live sessions. Let's specifically talk about, kind of the severe hypothermic patient who's either peri-arrest or in cardiac arrest. What are some rewarming modalities that you're going to use in those patients?
Yeah, an important point here is that when a patient is in cardiac arrest, and as our listeners know, there's either passive or active rewarming. But it's the active rewarming that's really in play here, like you said, in these cases of severe hypothermia, especially if the patient's in cardiac arrest, right? That's what you got to do. And that might be something like, a chest tube or peritoneal lavage is actually simple to do. I've done it. It's a midline incision. It's a lot of warm fluid. I'm not sure what it is. I think it's like 140 degrees Fahrenheit to 106, something like that. That's a fair range, I think, to start lavaging. There's bladder irrigation too, bladder rewarming. These are all things that I think work well, but you got to do it quickly and with a trained crew, trained staff, and do it sort of side by side. You can't say things like, okay, so the patient's in cardiac arrest now, let's go ahead and do a bladder irrigation and see if that works. You just can't do that. Sometimes they need all three measures at the same time. They might need an OG tube, a peritoneal, lavage, bladder irrigation, things like that, simultaneously to get that temperature up as quickly as possible into that moderate range where now your cardiac medications might have a better chance of working. Right. So I'm very aggressive with treating patients like this. Have I ever done thoracotomy of hypothermia? I never have. I've never done a thoracotomy to wash out the chest for someone who's that cold. But I do start things, side by side and not do things sequentially because I don't think that's effective.
Yeah, you need to kind of
you got to
get all those interventions started.
Yeah, sure. The most effective one, obviously, is ECMO, right? ECMO is the most effective, the quickest way of getting the body warmed up if you have the staff and the capability, which many places don't have. So I think although the ECMO data is great in terms of rapid rewarm, it's fantastic. It's not going to work if you aren't trained for it or if you can't support it. So you have to make sure that you do it only if you are able to do it.
Yeah, no,
but it is the best. It is the best way of doing
it. And I mentioned that I worked, as a medic. I spent 10 years, doing air transport, helicopter EMS. We oftentimes would transport patients to tertiary care centers capable of doing ECMO for that very reason. If you don't have that available as a resource, it's a consideration to transfer those patients.
Yeah.
They're very technically difficult transfers, though, right? Especially if you're doing CPR for prolonged periods of time during, transport. Those patients are not likely to have good outcomes, but certainly it's worth a shot if you have that as an available resource to you. And those are important things, I think. And you mentioned this, that people are trained. I think those are important things that if you are, have patients that present with hypothermia to your setting, to practice those and to stimulate them and to make sure people know how to use the fluid rewarmers, know how to, instill, bladder irrigation. Those are things that you aren't going to be doing that often. And I think it's an important point that you bring up, that just repeat, training, simulating, and practicing those kind of things is really, pretty important. So let's get back to your case. You left us on a cliffhanger with this guy, getting ROSC. And so what happened from there, and what were some of the take-home points from that case?
Right. Right. So, as anytime you have a patient who's young, right, young, viable, who's actually a college student, parents get involved, and it's terrible. It's awful. It's emotional and extremely distressing. He actually had a prolonged resuscitation in the ER. He had, invasive active resuscitation being performed. Medications just weren't effective, so he had to have prolonged CPR. And so imagine all the complications of that, fractured ribs, pneumothoraces, the whole bit. Just the long downtime basically was the most catastrophic thing that happened. And, he actually made it. He eventually had ROSC and made it to the ICU, but unfortunately did have a lot of residual brain injury. It was a difficult thing for everybody. Everybody was just mortified. And people, did the best they could. But sometimes despite your best efforts, patients have bad outcomes. And that's a really important thing to understand,
And you are a big people who follow you on social media, and people who work with you, but other people who follow you on social media, and many of your programs and educational programs know that you're a big proponent of debriefing and checklists and debriefing, and that stems from your experience as a pilot and as a flight surgeon. How do you debrief on a case like this? And do you have a hypothermia? First of all, actually, do you have a severe hypothermia checklist that you use? And second, what kind of methods do you use to debrief these kind of cases that are, young guy, critically ill, really complicated case?
Yeah. So yes and yes. I do use a hypothermia checklist that puts me in the correct ballpark of identifying a patient who truly has hypothermia. And when they are severely hypothermic, we fall to a T. It's not done by everybody. I understand that. And most ER doctors probably would not use something like this, but I do. I have several sets of checklists that we use, as we use in aviation, to deal with things that are absolutely, a sort of a non-miss scenario. You can't miss certain things, right? This is the perfect example of that. And the debriefing part, yeah, absolutely. And for my days as a flight surgeon, I've been using, doing debriefs with my staff, my crews. And one of the challenges, when we did a flight mission in the military, you do a flight, come down, things aren't well, you debrief and you have time, you just have time. You can take hours to debrief a case. The ER is a very, very different animal, right? You have a case like this that takes whatever, an hour or more, and suddenly everyone's washed out. Your endogenous, adrenaline's depleted, and you go out and the ER is still buzzing. You got to take care of the next patient, and God forbid another case comes right in, right?
Right.
So it's really hard to debrief your staff on cases like this because it just takes time. So what I use is something that I call the 5-minute debrief. And quite frankly, it takes less than 5 minutes. So the first thing I do is I tell people before we even start, I say, listen, this is going to be a difficult case. It's coming in. We're going to do it. And we're going to talk about it at the end of it in the debrief. So don't leave. And after the case, I summon the entire crew in, and I'm talking about everybody. I'm talking about not just ER staff, docs, nurses, but I'm talking about, RTs. They are key in things like this. EMS, right? ED techs, they're all involved. So I will actually summons everybody who was in the case into a room before I'll tell them, listen, you can spare 5 minutes. The world won't stop. The ER won't fall apart, but this is important. And I go through the 5-minute checklist, which is essentially 5 items, which is basically, I summarize very quickly what happened. We talk about what went well. We identify them. That's really important to do. We talk about what didn't go well. And it's important to say that it's not who didn't do well, but what didn't do well. There's absolutely no finger pointing, no punitive measures, no blame on anybody, but we identify what didn't go well. And in this case, a few things didn't go well because of the chaotic nature of it and all that. And then we figure out and we all talk about how do we make things better. We identify. And I have people actually grade themselves as to how they performed. And what's funny is that across the board, I've done this for a long time now, for 20 years, and people tend to actually be significantly harder on themselves after a case like this. And that is an important thing to recognize. And it is important because at the end of the day, we all go home and we all have to be whole again to take care of the next patient. And you can't go home thinking that you did a bad job. You can go home thinking that the patient didn't do well, the case didn't do well, but you didn't do a bad job because you are just as important as anybody else on the team. And there are reasons why things didn't go well. And sometimes, as you know, Steve, you have no choice. It just doesn't go well because it's just fate, right? You can't help it. And so it's a really super important point that I think is not done well enough or frequently enough in ERs across places I've worked, at least. What's been your experience with this? Am I one of the only people do it or does something like this?
I do it because I learned it from you. So that's where it. And also in my experience in helicopter EMS, it was a very important part to not only debrief the case, but also safety issues in the aviation piece. So I think, it's a great way to learn. It's a great way to self-reflect. And I think the most important piece that you talked about was making sure that you're going home feeling whole and feeling that your contribution was worthwhile and that not all cases go well and that it's not in one individual's, fault for that. It's usually just the system or the case or extraneous factors, but we're all here. We all are here to care for people and we all do the best we can. And I think, that's your take-home message is an important one. So I want to thank you again. We're joined again today by Dr. Sush Prusty, emergency medicine physician, pilot, an educator. You have a social media following on MyHeartMD, and that's on Instagram, and you do a lot of educational programming there. How else can people connect with you in social media or in other formats?
Yeah, social media is it's a crazy thing. It's an awesome thing. And I've met so many people through this thing called social media, right? This new platform. There's so many of them that I belong to some of them, but I've really focused my efforts since I like EKGs and EKG education, debriefings, checklists, things like that. I've been focusing my efforts on Instagram for now. And like you said, it's MyHeartMD. And my contact information is all there. So all
Great.
that stuff. If people would reach me and share cases, talk about stuff, I'm totally open for it. And I do. It's just, as a matter of fact, received 2 calls today on really cool cases that we'll share with people over the next couple of weeks or so. So feel free to call.
Well, great. Well, thank you all for joining us. If you like this podcast and are interested in more content like this, make sure to visit worldextrememedicine.com for links to an array of educational opportunities, news, job opportunities, and updates. Wemcast, wemcast.podbean.com for more podcasts like this one. And the wem.academy for podcast videos and updates on our upcoming live sessions. Make sure to follow us on Instagram, on Facebook and Twitter to keep up to date on content and news in extreme and austere medicine. And certainly make sure to join us either live or virtually November 13th through the 15th for the Extreme Expo, which is going to be in Edinburgh. And thank you all. Be healthy, be safe, and we'll just see you next time on the World Extreme Medicine Podcast.